Let's get started. The patient has an intertrochanteric fracture of the proximal femur to be treated using a cephalomedullary nail. The operation is usually performed under spinal anesthesia, but general anesthesia can also be used. The patient is supine on a traction table like this. A key issue in osteosynthesis of a hip fracture is proper reduction. Before starting the draping, it is important to make sure you get good fluoroscopic images of the hip with the C-arm in both AP and lateral view. Fracture reduction is performed before draping. The traction table allows adjustment of traction as well as rotation of the limb. It's essential that the leg is brought into slight adduction in order to allow successful insertion of the nail from the tip of the greater trochanter. The traction table is used for the purpose of reduction. The leg can be adjusted to abduction or adduction and also into flexion or extension. Adjustment of the rotation is also essential in the reduction of trochanteric hip fractures. Due to a trochanteric hip fracture, the limb typically rotates externally, and this is corrected by internal rotation of the limb. With the help of traction, you can also correct impaction of the fracture and obtain correct neck-shaft relationship. When draping, it is important to extend the draping high enough. The nail will be inserted obliquely from above at the level of the greater trochanter, so the drapes need to be placed cranially enough. Also, the patient's upper body needs to be bent to the contralateral side of the fracture, and the ipsilateral arm should be placed on the trunk, for example in a sling, so that it will not obstruct the procedure. Next, let's define the site of the incision. Palpate the tip of the greater trochanter and outline the direction of the femoral shaft. It is important that the incision is not made exactly here at the level of the tip of the greater trochanter, but cranially from it, since the nail will be inserted obliquely from above. To get a better idea of the level, we can use a guide wire like this. We place it here on the anterior femoral surface, then we take an image. It shows that the incision will be well on the proximal side of the tip of the greater trochanter. The amount of subcutaneous tissue in the hip area will affect how far obliquely above the tip of the greater trochanter you need to approach and how far proximally you need to make the incision. This is a fairly slim patient, so a few centimeters will be enough. The incision is made parallel to the femoral shaft. The lateral view may help to define how anteriorly or posteriorly the incision should be made. However, the aim is to make the incision parallel with the tip of the greater trochanter like this. Then we make the incision. Here, when approaching laterally and from a proximal direction to the tip of the greater trochanter, there are no critical anatomical structures just below the skin incision. You can proceed to the fascia with a blade and check by palpation that you're at the correct level. Then we take a retractor. Hemostasis should be done here in the subcutaneous area. Make a small incision opening in the fascia. After opening the fascia, check by palpation that you're at the level of the tip of the greater trochanter. This model of the left femur will help to demonstrate the nail insertion site. Higher up is the anterior side, and here is the posterior side of the femur model. The nail is inserted via the tip of the greater trochanter. We can divide this distance into 3 parts. In this view, we see the upper third and the middle third, and we aim at the junction of the anterior and middle thirds. And in the AP view, the nail insertion site is here at the tip of the greater trochanter. For the guide wire insertion, you can use this multi-hole trocar that allows you to adjust the guide wire location. You start by inserting the guide wire via the middle hole, and if in the AP and lateral views the location is not optimal, you can rotate this instrument in the desired direction and move the pin the desired distance. In this case, it allows an adjustment from 4 mm to 5.5 mm in the desired direction. Then, put the reamer sleeve with the multi-hole trocar in place and make sure that the guide wire makes contact with the bone. Then, under fluoroscopic control, we find the optimal site for insertion. Now the guide wire is at the tip of the greater trochanter. It is of vital importance that this guide wire comes from a very proximal direction here so that it is parallel as possible with the femoral diaphysis and thus prevents entering too laterally. In this case, if you start too laterally, the guide wire may easily end up against the medial cortex and even outside the bone through the fracture site. We then advance the guide wire a little inwards. Now, after confirming the guide wire location, in the AP view, we will take a lateral projection to make sure the wire is also at the right direction in relation to the femur in the lateral view. Remember to aim at the line between the anterior and the middle thirds. Now let's turn the C-arm around and take a lateral image. This image shows the normal anteversion of the femur. But from this view, it may be a bit difficult to see how the wire is positioned in relation to the greater trochanter. To account for this, we turn the C-arm parallel to the anteversion of the femoral neck by tilting the C-arm about 15 degrees, like this in the coronal plane. Now let's take another image. Now we have the so-called true lateral view. With this view, it's easy to ascertain that the wire is at the correct location. If we visualize that the pin continues straight forward, we can see that it's directed right towards the femoral diaphysis. Now that we've confirmed that the guide wire insertion site is appropriate, we drill the guide wire further in. We can direct it even slightly more medially. The image looks good. Then let's take the true lateral view as well, using the 15-degree tilt as mentioned earlier. The wire appears to be nicely located in the intermedullary canal in the femur, also in this lateral view. Now, we start opening the femoral cortex using this shorter reamer with the reamer sleeve for the proximal canal. For these short cephalomedullary nails, there's no need to ream the diaphysis, so the shorter reamer is enough. First, we check that the reamer is in the right place and take an image. It's important to note that in a trochanteric fracture, the fracture often reaches the tip of the trochanter, and strong pressure should not be applied during reaming. Reaming with substantial pressure may start spreading the fracture fragments apart and dislocate the fracture. With the reamer, the idea is to drill a tunnel in the bone for the nail. Due to the protective reamer sleeve, the reamer stops moving forward automatically when it has reached a maximum required depth. Therefore, the protective reamer sleeve tip must be properly against the tip of the trochanter. We have now reached the maximum depth with the reamer. When the reamer is pulled out, the guide wire often comes out with it. The wire should be placed back before inserting the nail. Now you can palpate the greater trochanter and check by fluoroscopy that the wire is still correctly positioned. Now that the guide wire is in place, we start inserting the nail. The femoral neck angle should be ascertained preoperatively from the intact side, as these nails are available with several femoral neck angles. In this case, we have chosen a 125-degree nail. You can connect this strike plate to the target device in case you need to impact the nail deeper using a mallet. But we start introducing the nail by hand. It is inserted with gentle rotation. Rotating too vigorously may cause fracture dislocation. To avoid dislocation, it's safer just to tap gently with the mallet. In this way, the fracture is not subjected to any twisting forces. Using fluoroscopy, check that the nail starts advancing and has reached the right depth. Before final adjustment of the correct nail position, the guide wire is removed. It's now essential to check that the nail is at the correct depth and in the appropriate rotation. To determine the correct location for the lag screw in the femoral neck, we can use this targeting tool called one-shot device, which is first connected to the guide sleeve of the lag screw. On this device, you can see here these two solid lines and a string of beads between them. In the fluoroscopy image, when the string of beads is just between the two solid lines, it tells us that the C-arm view is completely perpendicular to the targeting tool. Let's take an image. The image shows that the nail is slightly proximally, and we need to impact it further distally. we impact it still a little bit more distally. Now it looks very good. As you can see, the string of beads is just between the two solid lines. The aim is to get the lag screw in the middle of the femoral head, so that the tip-apex distance, meaning the sum of the distances from the tip of the lag screw to the apex of the femoral head in the AP view and lateral view, is below 25 millimeters, so as to minimize the risk of cutout. After confirming the correct nail level from the AP view, we confirm the correct rotation from the lateral view. We remove the strike plate. We then tilt the C-arm to get the true lateral view again. You can now see from the image that the nail needs to be rotated slightly inwards. In the image, the anterior side is here at the upper left and the posterior side at lower right. Accordingly, you can see that the nail should be rotated a little inwards. We now have a good lateral view showing that the nail is directed right towards the middle of the femoral head in the lateral view as well. Next, we start inserting the guide wire into the neck of the femur. We make the skin incision just here where the guide sleeve points at. We then use scissors, which can be used to go through the fascia and bluntly tunnel the root all the way to the cortex of the femoral bone. Then put the trocar into the guide sleeve. Check from the image that the guide sleeve is properly against the lateral cortex of the femoral bone. Then, the lateral cortex is first opened by drilling. We then change the trocar to match with the guide wire gauge. The guide wire is inserted subchondraly, so very close to the femoral head joint surface. In this case, you can see the bone is very hard. We then check the lateral view once more. Even though the one-shot device was used, the nail rotation may change during insertion of the guide wire. Therefore, we need to check that we're definitely in the middle of the femoral head, also in the lateral view. We can still go a little further with the guide wire. Let's take a closer look at the guide wire position from this fluoroscopic image. In the AP view, the wire is usually just inferior to the midline so that we get it right in the middle of the femoral head and targeting to the subchondral bone. In the lateral view, this is the femoral head, and also here we aim right in the middle of the femoral head with the guide wire and just subchondraly. The location of the guide wire is of vital importance because if the pin is too cranially, then in an osteoporotic patient, there's a risk of screw penetration. Then the screw penetrates the femoral head cortex cranially or the articular surface. This leads to failure of the fixation. When inserting the lag screw to the border of the middle and the lower thirds of the femoral neck, there's more distance to the cranial cortex of the femoral head. In consequence, there will be reduced risk of this kind of cranial penetration of the lag screw. It's also of great importance to note and remember that when measuring the lag screw length according to the depth from the guide wire, the measuring tool automatically subtracts 10 millimeters from the measurement. Thus, when you read the measuring scale, you should consider how close to the cortex of the femoral head the guide wire is inserted. If it is very close, the measurement should not be rounded upwards. Otherwise, the tip of the lag screw may come too close to the femoral head cortex, causing again a risk of penetration of the screw. Now we measure the length of the lag screw. The scale now shows 103 millimeters. As you can see in these instructions as well, the measuring device automatically subtracts 10 millimeters from the guide wire length. Now, since I have inserted the guide wire a few millimeters below the cortex, I will round the measurement up to the higher reading, so we select a 105 millimeter lag screw. We then drill a tunnel for the lag screw. The drill is adjusted to the correct measurement of the lag screw chosen before, which we've now chosen to be 105 millimeters. We remove the inner trocar. And we check the position using fluoroscopy like this. The guide wire often comes out with the drill. It should be put back before insertion of the lag screw. We check by fluoroscopy that everything is in order. The chosen lag screw has been connected to the insertion tool and we start screwing it in. These grooves on the screw surface, there are 4 of them on the screw 90 degrees from each other. It needs to be noted that the lag screw should be inserted so that in the end one of these grooves points upwards towards the proximal tip of the nail. In practice, the lag screw insertion handle should be either parallel or perpendicular, i.e. at 90-degree angle, to the target device handle. It must be noted that in case of a basal femoral neck fracture, dislocation of the fracture may occur from the base of the femoral neck when screwing the lag screw. In order to prevent this, you can insert another wire to serve as an anti-rotation wire, thereby first fixing the fracture in place. This risk is in particular in the insertion of the lag screw into the left hip, less so in the right hip. This is due to the difference in direction of the screw rotation relative to the fracture. Now, when this mark on the insertion tool comes exactly flush with the guide, the depth should be just correct. The depth appears to be good in the image as well. Then we confirm the appropriate location of the screw also in the lateral view. This appears to be fine as well. We can lift up the C-arm. As mentioned before, we should check that this handle is parallel to or at 90 degrees to the target device and at the same time with the diaphysis, so that the groove on this lag screw is now upwards. Next, I will lock the screw so that it will allow sliding but prevent rotation. Now that the screw is at the correct depth, there may still be a fracture gap, and this insertion tool can be used to compress the fracture by turning this thumb wheel on the insertion device. But you should be very careful with this if the bone is of poor quality. In such cases, the device may pull the screw off the bone instead of compressing the fracture gap. Again, check the rotation of the insertion tool. These marks on the insertion tool also help to ensure the right alignment of the lag screw. Again, the handle is either parallel to or perpendicular to the target device. Before removing the lag screw insertion device, you need to place the set screw, which is inserted from the proximal direction into the nail. For this purpose, this guide tool can be used, which I connect to the target device. Then, using a flexible tip screwdriver, we insert the set screw. We start turning the screw and tighten it fully and make sure there's no rotational movement here on the lag screw handle. Then we unscrew the set screw a little, about 1/4 of a turn, so that there is slight movement here, allowing the femoral neck screw to slide, but preventing it from unscrewing. To prevent implant failure, do not unscrew the set screw more than the earlier mentioned 1/4 of a turn. Next, we place the distal locking screw into the nail. But before doing this, you need to make sure the target device is still tightly in place. Sometimes it may loosen a little when the nail is inserted to the right depth. If this happens, the target device will no longer target to the right place. Now we insert the distal locking screw by first removing this lag screw guide sleeve, which is no longer needed. Now, when turning the speed lock sleeve, we see the different neck angles and the selection of locking screw options, which are static or dynamic locking. In fracture settings, we usually select the static locking option. The guide sleeve is used to localize the skin incision site. We advance down to the bone surface bluntly with scissors. We place this locking screw guide sleeve with the trocar against the bone surface. We can check by fluoroscopy that it's in place and tighten it in place from the black knob of the speed lock sleeve. Next, we start drilling. It is important to remember that there are vital structures on the medial side, such as branches of the femoral artery. Drilling of the medial cortex needs to be done with caution to avoid unnecessary damage to the medial soft tissues and blood vessels. You can drill under fluoroscopic imaging, and when you have gone through the medial cortex, take the reading from the drill. In this case, we select a 40 millimeter long screw. Then check from the lateral image that the screw has definitely gone through the nail. The screw cannot be seen at all, so it's definitely gone through the nail. After this, you can start disassembling the instrumentation and start wound closure. Now remove the target device, like this. The limb traction can be released, and we can obtain final fluoroscopic images. First, the distal part of the nail. Then we move proximally. Then the true lateral image by tilting the C-arm 15 degrees. We bring it a little more distally here. We see the distal end of the nail. And now we move the C-arm aside and start wound closure. We use absorbable sutures, Vicryl 0, for example. Close the fascia first, then the subcutaneous layer, and finally the skin. Hemostasis should be checked. It is possible to place an end cap on the proximal end of the nail to prevent bone ingrowth. In young patients, the nail may need to be removed in the future, so placing the end cap should be considered. But in elderly patients treated for hip fractures, placing the end cap is not necessary. Then absorbable sutures such as 2,0 Vicryl in the subcutaneous layer. Hemostasis can be checked again, and if necessary, cauterize the bleeding. then the skin sutures. It is also possible to close the skin using surgical staples. Closure of the skin alone is enough for the distal wounds. Finally, the wounds are covered with wound dressings. And after the operation, full weight bearing is usually allowed. In other words, a hip fracture should be operated on and fixed in a way that allows immediate weight bearing if possible. Regarding recovery, it is of vital importance that an elderly hip fracture patient can be mobilized immediately after the operation.